there and what you would want to do. However, unlike some of the other things, I only pick the groups. So you don't have to learn percentage and this and that and yada, yada, yada. Would this individual need group 1, which is what? The strongest ones, or is it going to be group 7, 6-ish? That's what I like to do with those things. Same thing for the antibiotics. It's just knowing which of an antibiotic I would use for this type of a diagnosis. Okay, so you would just have to know. Again, not of the dosing, but of what would be used to do that there. Okay. Now y'all know that this is dermatology, so there are pictures that are out there. Okay. The pictures that are on the slides are not going to be the pictures that are on the test, but they're going to be similar, aka almost identical. Okay. The first test has about 20 pictures or so, but then once we get into these other ones, then it's going to have a lot, because we'll be talking about the benign stuff first, and then we're going to talk about the bad stuff after that. So you will see those things out there. Like everything, the number one thing is for you to keep, or you to understand and know all of the key components, right? What is specific for this one of a diagnosis that is jumping out there, because I'm going to throw it to you, right? Nummular eczema, what does it look like? A coin, right? So you'll see some specific components out here that will show you those things. And so that's the only thing that I want y'all to hear those things, okay? Any questions about what dermatology is going to be? Again, it is the 3 blocks, so 3 tests, and then after that, we are good to go. This is, I think you have me for 5 weeks with the 3 tests in there, and then I have to say goodbye. But I'll still be with y'all through all of the other stuff, okay? All right. Today we are talking about some of the diagnosis of the skin disease. So this is breaking it down into all of the things that specify what these things are. So we're going to talk about the creams, or the topicals, da-da-da-da-da. I'm going to talk about the bullae, the vesicles. I'm going to talk and describe what these things are and how you see those. Then afterwards, we're going to talk about the topical therapy and of the topical the corticosteroids that are out there, okay? That noise that you hear is because it's hot as hell in here, and I took over the fan right here. So, FYI. It was going like this, and there's no one sitting there, so I'm okay. I'm sitting here. Well, all right. So let's get into these things here. Again, I also told the class leader that I am one of those that is willing to proceed on, or to start early, or to go late. I'm okay with all of those things, as long as I'm on campus, right? So that is good to go. This is like 61 and 47 slides, so once we're done with the first one, I'll ask, okay? All right, so as I said, we're going to get into the diagnosis of the skin disease, right? Habibs, y'all, I don't know if y'all already know, but the Habib is like the Bible, okay? Everything in there is, you know, there. I've always pointed that out and used that with all of the classes before y'all who would go to phase 2 and then have a dermatology test. But guess who doesn't have to write those anymore? This guy, because you're not going to be taking any of a dermatology test while you're out there. Yes, you're still going to get it in the family practice, the pediatrics, and all of that fun stuff. But anyways, yeah, there we go. Again, y'all know all of anatomy, right? Y'all went through all of that stuff. Before you even got here, you had to go through A&P 1 and 2 and all that kind of stuff, and then you came here and you repeated it. You had to do it again, right? So you're all sitting here because y'all did well. Anyways, that's that picture. Bye. All right, so breaking it down, right, one of the things that are important on here is when we're talking about the epidermis, we have those 5 spaces, right? So we have that of the basal, spinosum, granulosum, lucidium, and the cornea. And then you can see all of the key components of the diagnosis of those things there that are showing you what they are. As we can see, of the epidermis, it's not the same everywhere that it goes. If it's the eyelids, then you know it's smaller, it's thinner. If you have it on your back, then it gets a little bit more, right? So you've got more of the deeper. Y'all know that because if we're going to have to start an IV or to do any other invasive aspect, it'll be different areas of that subcutaneous fat. So as we're going into that stuff, it's not always going to be the same. Okay? So that's that. Again, I'm not a big one on anatomy because you have already done that. So I'm just scrolling through these components there. That is of that breakdown, right? So you can see the different levels of that area all the way down once you finally get into that sub-Q area. Dermatology is a morphologically oriented specialty. Okay, they're very special individuals because they know everything about things head to toe. I promise you that as you're going through this, and once we get into the diagnosis, y'all will be walking through Target, or you'll be walking through, I don't know, at a bar, and you'll see something and be like, ha, you know what that is? Have you cleaned it yet? Have you done this? Have you done that? Right? So you will see those things, okay? Diagnosis of skin disease must be approached in an orderly and logistical manner. So we're going to avoid that temptation to just make of a rapid of a diagnosis, okay? You have to look into those things. You have to ask the medical history, family history. You have to ask all of these things, which y'all are experts in all of the SOAP notes, so you know how to ask these things, okay? So we're talking about recommended approach to a patient with skin disease. Damn, I just pretty much already said these things, right? So of the history, of the physical exam. So what type of a patient is it? Is their pigment of a 1, so they're from Ireland? Or is it from a lower one where it's like Africa or some other oven areas? I mean, we're going to get into all of that specifically when we get into block 2, where we're going to break it down. Okay, distribution, where is it at? What was the first one? What is the second one? What was happening when all of this, you know, out there? We obviously, or not obviously, awesome, always, see? Awesome have of those, the differential diagnosis, okay? Some of them will have some tests. We'll have to do some of the labs. We'll have to get some labs before we send them out to a specialist, just to give them that a precursor to help them out, okay? Again, you know what all of that stuff is, okay? History, duration, allergies, medication, medical history, family, social, okay? Obviously, once we get into block 2, we're going to talk about the bacterial, we're going to talk about the fungal, we're going to talk about the viral, so we're going to talk about that sexual contact oftentimes. Ask about, you know, some of the irritants. What type of soap do you use? Shampoos, lotions, perfumes. Do you go to Sephora, right? That's those things that are just pointing those out. My 15-year-old daughter loves Sephora or Ulta or whatever. And I always tell her, anyways, it's her mom who takes her over there now. Laundry detergents, occupational exposures. So what do? Are you always outside? Are you protecting yourself? Are you having some of those things to where you're a dishwasher, so you're washing over and over, so you've got all of that moisturized that are in there. Physical exam, I talked about the Fitzpatrick skin of a phototype. Again, we'll be talking about at the end of block 2 there, pointing those things out, but where are they? What is their skin like? Distribution, so it started here, and did it spread out like the pityrized rosea? Did it start here and then now it's the lymphatic that it's traveling through? It's just back and forth with those things out there, okay? Again, primary lesion, secondary lesions. Description of those lesions, right? So how many are there? Is it actual or is it generalized? What does generalized mean? It's all over, right? So we're going to get into impetigo of the kiddos, right? Is it only on their mouth and of the nares, or do they have it going all the way down their arm to wrist to of their trunk all the way down? Well, that's generalized, and so there's different prescriptions or the treatments that would be there. Size, small or large? What's the color? Is this the first one, or is this the second, the third, the fourth one out there? Distribution, we talked about that stuff up top. Configuration and of the palpation. Is it firm? Is it soft? Is it those things out there that would be there? You all know what a ruler looks like. Talked about the color, right? So erythematous, necrotic, cyanotic, hyperpigmented, villaceous, hypopigmented. It's breaking down into what of the color that you're actually seeing out there. So those are what they mean, right? Some of this y'all know perfect. Just doing physical exam, I had always said, yeah, you could say erythematous, or you can just tell me that it's red, erythema, like you can do those things out there. But in here, now this is more didactic, so let's know what those are, because it could be of a question just describing what it is that you are seeing, okay? That was one of the things that I forgot to say, is that every single picture will have of a question with there, pointing out, describing, doing all of those things. So it's not just going to be a picture and say, what is this, right? It'll have all of the vignettes and the stems, and it'll have those things up there. So, yay. Total body surface area. If you've got something on your arm, well, we're going to have to look on your ass and your toes and your head and everywhere from head to toe, okay? That is one of those things. Because you only see it here, well, where else can it be? Okay, because that helps us with all of the differential diagnosis and to point those out. We're going to talk about some of the cancerous out there. You know, how many times do they have to be seen? When are they able to stop? We'll get into those things. Solitary, multiple, localized, generalized. What's the pattern, right? I talked about pityriasis rosa, which we'll talk about in here. It's got a primary lesion, and then it spreads, and it looks like a lovely Christmas tree. What is the pattern? Yeah, I just said that. Describe what you see and what you feel. Okay? Again, this is more of the distribution patterns. Okay? I've said a lot of these things already. Okay? Is it localized, solitary? Is it spread out? Is it only on one side, or is it on both sides? And y'all will see that we have some of the conditions that only stick to one side. Sun-exposed areas, we got flexor or extensor surfaces, right? So eczema is more on the flexor, so it's inside of the elbows. Psoriasis is on that outside, right? So I got psoriasis all over, and I'm sure I've told many of y'all when I was doing physical exams with you, so don't think that I have fungal stuff on my fingers, because it's my psoriasis that just grows in there and it loves it or something. So I'm not sick, okay? Where is it at? Is it on intriginous, right? So that is up and under of the stomach. It can be up and under of the breast, the armpits, those areas. Acral, hands, feet, ears, and nose. Seborrheic regions, orificial, so it's inside of the mouth, also known as mucosal or linear. So here are some pictures of it, okay? So of a solitary lesion, you are going to see pictures like this in block 3, because that looks like it's some type of a melanoma, because there's none of the borders, because it's not one of a color. It's getting into those areas, okay? Multiple lesions, does he? Hell yes. Okay, put a hat on. Okay. Multiple lesions, you can see these are localized. They're only on those forearm places. So they're localized as opposed to an individual who's got it all over. So it's generalized. So he's got it on the trunk, he's got it on the arms. If the picture goes up, he probably has it on his face. Who knows? Okay. Dermatomal, what do y'all think that one is? Huh? Shingles, right? Because it's got that the one of the dermatome. Once it gets into that dermatome, and if you treat it and it goes away, it's probably going to return when it wants to have a party. Okay? I talked about the flexural, right? So that's more of the inside, specifically seen oftentimes with the eczema. Psoriasis, so it's that extensor. So that's of the elbows, of the knees, those are the flexor areas. I talked about intriginous, so up and underneath of the breast, of the waist. It just depends the locations where it started at or where it still is. Linear, that's, yeah, what do you think that is? Poison ivy or something, right? It just scraped through that area, so you're getting some of the vesicles, some of the bullae that are at that area, and so that is called linear. Again, this will be all of your description of those things, so that in your mind you know what it looks like. Annular, serpiginous, clustered group. So erythematous on a clustered group, right? So that's one of your STIs. Serpiginous, that could be some of that areas where it's just traveling and it's up and under. Annular, ringed. So again, description. This is just pointing them out to y'all as we're going to get into those as we press on. Cutaneous, is it soft, is it firm, is it hard? Can you push on it or can you not? Is it tender to where they want to kick you, or is it non-tender? Blanchable, non-blanchable, what is that like? That's if we're going to press on our nails, right, and then we let go, we can see that come back because it's cap refill, right? But this could be happening on some of the skin conditions that are out there also. Rough, smooth, mobile, fixed, dermal, subcutaneous, what's the temperature, and others. So here is an example of that. Multiple, small, erythematous papules and vesicles localized to the volar surface of bilateral forearms and antecubital fossa with excoriations and lichenification of the wrist bilateral. So that's a wonderful way to just say, he's got some shit on his forearms that doesn't look like it is awesome. Right? So we're not going to say that, we're going to say all of the wonderful stuff that's up there. Okay? Again, we talked about primary lesions. Okay? So primary lesions, most skin disease begin with a basic type of lesion that is referred to as the primary lesion. Where did it start? Well, it started here, and then now it's out. Okay, so you want to know those things. Identification of the primary lesion is the key to accurate interpretation and description of the cutaneous disease. Okay, an example. So of primary lesions, that can be a macule, a papule, a plaque, a nodule, a pustule, a vesicle, bulla, and wheal. Okay, so it's going to show those things out there, and then you will make what type of a primary lesion is that. So we're going to break them down. So there's that macule, a circumcised, how do we say circumcised? I always say circumcised. Circumscribed, okay? Probably I'm not trying to be any weird. It's just how it, damn, aphasia. All right. It's, yeah. of the flat discoloration, all of those things out there, okay? We can have a patch, so that is the same thing as of a macule, but it's greater than 1 centimeter. So if you think that it looks, and it is a macule, but it's big, so it's greater than 1 centimeter. Less than centimeter, okay? Greater than or equal to 0.5 centimeters in diameter, that's that elevated solid lesion known as a papule. Plaque, I'm not going to say that word now. You know what it is. Elevated superficial solid lesions greater than 0.5 centimeters in diameter. So it's larger. We can have a nodule, elevated, greater than 5 centimeters in diameter, but a large nodule is referred to as a tumor because it looks like something is odd. Of a pustule, collection of leukocytes and free fluid, so it's got that pus that varies in size. Talked about a vesicle, collection of free fluid. So we can see those there, less than or equal to 0.5. The bulla. Looks like that stuff that we saw on that linear area, right? Those are called bulla. So it's collection of free fluid that's greater than 0.5 centimeters in diameter, and one of the key components of it is that you can see how it's got that fluid inside of it. If we were to pop it, then it would drain. So that's what a bulla is. Wheals hives. Firm edematous plaque resulting from infiltration of the dermis with fluid. So you can have something that exposes this to respond. However, you can also do some of the testing that's often done with allergies. They'll do of the lines, like they'll do one of them, and then they find which one pops that up, and we can see that it's the Navy. My man. All right, secondary lesions. Lesions that are characteristically brought about modification of the primary lesion. So it's that second stop. Okay, so you don't start with the first one, but you get that one out there. These things can happen either by the individual with the lesion and they spread it or they move it away because they're scratching at it or because they're, applying some of the stuff that doesn't need to be happening, which is what we say right there. Maybe the only type of lesion present, so must infer primary disease process. So you can't have a secondary lesion unless you started with the first one, okay? Examples here: scale, crust, erosion, ulcer, fissure, atrophy, scar. Those are the things out there. So let's take a picture or look at pictures of them all. So we got scales, excessive dead epidermal cells that are produced by abnormal keratization and shedding. So you can see some of that on the left. We see some of that scrapping. LSC, so lichen simplex chronicus, is on that right foot, and it's because those individuals just scratch at it or they use the other foot to scrape it. So those are those scales. I talked a little bit about impetigo, right? That oftentimes seen as that crust. So we can see it in those areas. A collection of dried serum and cellular debris. So that's that scab. Erosion, a focal loss of epidermis. So you get those things that do not penetrate below the dermo-epidermal junction. So it's staying out. It's not down and into it. It's staying out. So you can see that erosion. So let's think about erosion as a volcano or something. It's just out. Like it's not deep down. All right, here we go. Ulcer. A focal loss of epidermis and dermis. So it's got that ulcer that if it even goes away, that it can keep that scarring that is out there. Fissure. So it's like a linear loss of the epidermis and of the dermis that is sharply defined. So it's on the vertical walls. So you can see that on of the lips, right? You can see that is of a fissure. Atrophy. Depression of the skin resulting from thinning of the epidermis or of the dermis. This can be just because of weight. You know, some individuals who are having some of a weight loss, well, the atrophy signs can still be there. You can have telangiectasis, which is what you see on that right one, that shows of those capillaries that are spread out, so you can see those on of the face. You can have some scars, so that's that abnormal formation of the connective tissue, implying some of the dermal damage, right? So if you were cut and you get a scar, y'all all pretty much know what scars can be, right? We can have those things anywhere if we are exposed to some trauma or some surgery or something else, right? So special, secondary, but we also have special lesions. Again, that's not the primary or the secondary, it's in and of itself. So excoriation, comedone, milia, cyst, burrow, lichenification, telangiectasia, petechia, purpura. Okay? So let's break those down again. So excoriation, scratching. It's linear because of the fact that they're going right there over and over and over, and so that's what will cause that excoriation. There's another picture of those things. So the back of the neck, or it can be pretty much anywhere, okay? If you want to go to a mental health clinic, you'll probably see this stuff everywhere with those cray-cray people. Because they just want to scratch stuff to scratch stuff. Comedone. That's part of what? Acne, right? We got the white or we got the black, and it just depends on where they're at. So that's that plug of the sebaceous and of the carotenoid material lodged in the opening of a hair follicle, right? It can be a blackhead or it can be whitehead, which you can see on those two pictures right there. All right. How many of y'all have or have seen a baby that's got some of those things that are around the eyelids, and then you wonder, doctor, what's going on with my baby? Okay, that's milia. It is benign. It's not something there. It'll go away on its own. So it's a small superficial keratin cyst with no visible opening. Again, that is some of those papules that are around of the eyes that can be causing that. Milia. More fun pictures. A cyst. So we've got those lesions with a wall and a lumen. So the lumen may contain fluid or solid matter. So if we were to poke at that, we can get some of the drainage, some of the fluid, some of the cottage cheese stuff out of it, but those are that one right there. Okay? The burrows. So you got that narrow, elevated, tortuous channel produced by a parasite. So once the parasite gets into it, then it's going on a swim, right? It's just going back and around, back and forth. So that's a burrow. Lichenification, again, we talked about it a little while ago, which of that itching that can cause that thickening of that there. Telangiectasia, that's that dilated superficial blood vessel. So it's more of the caps. of the capillaries. Okay, so you see that individual's got it all up on the face, but then you can see that one over there on the right, what's inside of a nodule, and that's going to be a cancerous process, aka BCC. Okay, so that's out there. Now these ones right here are almost the exact same thing. It just depends on what size they are. So petechiae, deposit of blood less than or equal to 0.5 centimeters. Whereas purpura is greater than 0.5. So if you are told that you've got that deposit of blood, so you've got some blood up and under there, if it's less than 5, then we're going to go with petechiae, and then if it's larger than that, then we're going to go with purpura. Last of the things over here, differential diagnosis. Y'all know this. Every time that y'all do some type of a clean course, soap note, or if you're going to go through OSCEs, you always have to say, this is it, and it's not this because of this. It's not this because of this, back and forth, right? So you always have to have that of a differential diagnosis, okay? Again, those are based on the lesion characteristics, duration, on-site symptoms, and distribution. Most skin diseases have preferential areas of involvement, right? So we know that if we've got some of the eczema, then it's on the inside. Cirrhosis on the outside, you know, those things there. Disease locations and different diagnosis based on the distribution elucidated by Habib. Test. Talked about this, right? We need to get some of the labs, or we need to get some additional factors that help to prove or to let them know, hey, boom, da, boom, da, boom, right? So these are a list of the tests that are out there. Biopsy, shave, punch, excisional, KOH, fungal. If you're going to scrape at it, yeah, that could be some type of the scabies. Gram stain, culture, cytology. That's that zinc prep that we're going to talk about in block 2 once we get into those herpetic diagnoses. Wood's lamp. That's going to be one of the things that we talk about on the next block as well. Because some things, whether they're fungal or bacteria, some will look beautiful red, some will be blue, some will be this, that, back and forth. So we're going to get into that. Talked about the patch testing. I don't know if you've ever had it, but they will like tattoo your entire back with all of the diagnoses on there and see what actually responds there. Blood test. Like I said, we would want to do some things. If we're already sending them out to a specialist, then we would want to get an ESR. We want to get of a CBC. We want to look pregnancy. We would look for some of those things out there that we would need. And dermoscopy, that's just having a wonderful thing that you can look through it like it's a scope, right? That's what that is. Again, we know approaches to the treatments, right? There are 4 main treatment categories. Are we using some type of a topical, whether that is of a steroid or some other things out there? Systemic, right? So we're going to give them some of the PO medications. We're going to give them some of the medications for them to take. Surgical, we're going to cut it off. We'll learn about that once we get into the BCC, SCC. They do some of that Mohs surgery that actually take those things off, or we're going to do phototherapy. So they're going to put you in that bed-like booth that you stand in for like 30 seconds, you know, up to something else, and it's just, you want to be dark. So that's what we talked about with all of this stuff. Again, this was just of the first step in all of these things. You're going to see all of those terms used throughout everything, okay? So that is that. Up next, we're going to go into some of the real stuff. Would y'all like a break? Break? Okay. 10 minutes and then we'll start up again. And that one will be quick as well. All right, so let's get with talking about all of the topical stuff, right? So we're going to talk about just some regular stuff, right? If you are dry, make it wet. If it's wet, make it dry, okay? What is the what is the thing that makes the most dry? It's a joke. Towel. Get it? All right. It was a joke that Commander Irving, he had it on like one of his jokes of the day, so he brought that one. I'm going to put it on my desk, and I said, I'll make that a test question. I'm not going to, but still funny, okay? So we're going to talk about all of the topical therapy, right? So I said wet and dry, okay? We're also going to talk about the corticosteroids, so strength, vehicle. What is the vehicle? Vehicle is how we're going to use it, right? Is this going to be an oil, a cream, back and forth. Applications and adverse reactions. Like I said, if it's dry, wet it. If it's wet, dry it. And how are we going to do those things? Let's not just use a towel, okay? Purpose of topical therapy: restore normal skin function after an insult, removes water, lipids, and protein from epidermis. Basically, we want to alter integrity of the skin barrier and compromise function. So what we're getting into is to manifestate or to work those things out the way that we want them to do. Dry disease, okay, we get those cutaneous lesions, can have moisture. In most instances, it can lost epidermal lipids and proteins which help contain moisture, so that moisture isn't trapped in those areas. It's out and flying away. We need to replace that moisture with emollient creams and lotions. Again, those are part of the vehicles that we're going to get into towards the end of this slide deck. So dry skin, what do we call that? Xerosis cutis. So that's described as rough skin covered with fine white scales, progresses to thicker tan or brown scales. If it is severe, then you got that crisscrossed, jump, and fissured ones, okay? So those are some of the things. I'm probably the oldest one who remembers crisscross. Anyways, worse in dry winter months, most commonly affects the hands and lower legs. It'll itch, it'll burn. It's not always, but those are some of the things that we can see because of the fact that it's just drying it all out. Treatments, we use those emollients, lactate lotion. Again, we're going to go through all of those things and check them out, as we can do right now. So those things restore water and lipids to the epidermis. So it's almost like giving them a good meal, right? So it's trying to build it up. Those with added urea or lactic acid all have special lubricating properties. The creams are thicker and more lubricating than lotions, right? So we're putting a cream onto it. It's not just going to absorb right away, but it's going to get into there where it needs to go. Most effective when applied to damp skin. So after a shower or a bath, pat dry and immediately apply moisture. Apply as frequently as necessary to keep skin soft. I've told y'all many times that I have the psoriasis. I will take a warm shower, jump out, and put my corticosteroid all over, and then put on all of the covers just to help. Does it work? Not always. Sometimes, yeah. Menthol and phenol can be added to reduce itching. There's xerosis cutis. So it's those dry things. Again, we're going to break down all of these in individual aspects, but basically xerosis cutis means dry skin. Okay? Wet diseases. So exudative inflammatory disease leaks serum. Leaches complex lipids and proteins from that epidermis. Management, wet compresses, right? So wet disease, again, they don't have that, so we want to go ahead and get that there. So if we use those wet the compresses, we suppress inflammation, debrides the crust and serum. Repeated cycles of wetting and drying eventually dry the lesions. Excessive use can over dry, causing severe drying and chapping, so they could get some of those fissures, some of those areas where they're taking out too much. Once wet phase is controlled, restore the lipids and proteins with emollient creams and lotion. So we're going to stop of the wet of the compresses, and then we're going to just treat them to inhibit any type of progression. Benefits, inflammatory suppression. So it stops that inflammation, stops that itching. It just gets rid of those things. So it evaporates, cooling, constriction of the superficial vessels, and then decreased redness, right, erythema, and serum production. So it controls that inflammatory process. A little bit better than the corticosteroids as well. Wound debridement will get that vesicle and crust off. Drying effect, antibacterial action. So it's with those ones that we talked about, urea, that can also add that aluminum acetate, acetic acids, and silver nitrates that help with that. Wet dressings, again, valuable aid in treatment of exudative skin diseases. So that's breaking it down into some of the things that could be there, and these are what the wet dressings can help, right? So poison ivy, impetigo, eczema, herpes, bites, intertrigo, nummular eczema, right? I told you that earlier. It looks like a coin. Stasis dermatitis, sunburn, tinea pedis. That's that nasty foot, right? Foot fungus. Again, here are some of those things that are specifically for those of the wet dressings. We've got breaking it down into that the acetates. So you get aluminum acetate, silver nitrate, acetic acid. Those are things out there that will help with those specific things, and you can see how it breaks it down in those indications. How do we use those? We're wanting to use 4 to 8 layers of clean, soft material. So you've got that in the picture there. You will wet the folding dressings in solution. So you get them out and you wring them out of all of that excessive. Place in the affected area, leave it there for 30, 60 minutes, 2 to 4 times a day. Again, we're going to discontinue once it becomes dry because we're going to jump into those lotions, and emollients. So that was all of that, but now let's get into the beast mode. So the topical steroids oftentimes prescribed. Okay? Look at that picture. Look at that picture. Those are awesome. I want you to memorize every single one and the percentages and of the dosage and all of that kind of stuff. I'm kidding. This is easy. I want y'all to know these right here. 1, 2, 3. Which is the most intense one? I said 1. I gave the answer. 1. Okay? And then there's all of the other ones. Breaking it down, you can go all the way down to a 7 hydrocortisone, right? So you can get that at Walgreens. You can get those things out there that are breaking that down. Again, I want y'all to know groups. Topical corticosteroid therapy. Effects of topical steroids. So that anti-inflammation, vasoconstriction, anti-mitotic. So decreased proliferation of the cells. One of the things that we will want to know is accurate diagnosis. So what is this? Because then once I know that diagnosis, then I'm going to know how much of a steroid that I would want to use. Proper strength, proper vehicle, okay? Vehicle, you will see this once we get into individual of the diagnosis, that I will tell you, you can use this vehicle here, but never this vehicle over here, right? So we're going to get into the foam. One of the key components of the foam is you cannot use it at all if they're less than 12 years old. So that's what it's meaning about here, is that you want to know what the proper vehicle is to use. Sufficient quantity, so how much will we be telling them how to do it? And at the end of this one, we're going to look at some of the infants as well as adults of how much of a fingertip that they will get. Appropriate treatment duration and follow-up. I told y'all that the group 1 is the strongest and the 7s are the weakest. Choose the right strength for the right condition. If it's been 1 to 4 weeks with what you thought was going to help, well then we need to have them follow up and look at it again. Concentration, do not confuse confound with potency, right? So that breaks it down into, that says clobetasol is 0.05%, but hydrocortisone is only 1%. To me, the percentages don't mean anything, okay? Yes, you will read in a textbook which one should be used, but the drug in and of itself, if you know which group that is in, then that's what you want to use, okay? So I talk about the vehicles. This is what we're doing, what we're using, how to give that. So the creams, the ointments, the gels, solutions, lotions, the foams. So we have to think about what it is. So let's break them down. All right, so here's a cream. Mix of organic chemicals and oils, water, and preservation. So you get that white color, and it's only got a little bit of grease in it. It's not a lot of grease. You can use it almost anywhere. Versatility is widespread. May cause irritation, stinging, allergy, if that's one of the things that is just not or should not be used for that. Cause medically acceptable, so if you're at Sephora and you put the makeup on, then you can use this one too, okay? Whatever. Drying effect with the long use, so if you're using this over and over, then they could actually make that stuff worse because you're giving too much. So when you prescribe one of these things, whether it is a cream of an ointment or that kind of stuff, you're going to tell them how much of the FTP, so that's the fingertip, and where to use it, how often to use it. You're going to let them know those things. Most useful for intravenous areas. So if you're treating something that is on the groin, the rectal or axillary, then this is what you would want to use, okay? This is a key one. Now, if you've used those things and it's not working, then you could change to another vehicle. But if you're in those occlusion areas, cream is the number one. Now let's get into ointment. It's like jelly, primarily greasy. It is greasy, okay? I told you how if I take a warm bath and for my psoriasis, I put that on, and I've got clobetasol ointment. So I rub all that stuff in, and then I put on long sleeve shirts and pants and all of that kind of stuff, because it'll spread anywhere. If you've got that ointment, I can hit the wall right here, and then I go away, and it's going to be looking like, oh, nice, what is that? Typically preservative free. It's translucent, so you can see the picture of it there, how it looks like that petroleum jelly. Most lipophilic, moisturizing, and occlusive. It's got that great penetration and that increase of the potency. So you're putting that in there and it works. 2, occlusive or acute eczematous inflammation and intriginous areas. So if you're having that in intriginous areas, we want to pick as a vehicle the cream. You can also have a gel, propylene glycol, water, sometimes alcohol that is in there. Don't drink it. Greaseless, clear, jelly-like consistency. Useful for acute exudative inflammation, as is poison ivy. Useful in scalp, does not mat the hair. Ointment, if you put it on there, they would have a flat hair because you're giving them, I don't know. I used to use one years ago, but I don't remember what it was. Anyways, yeah, useful of the scalp is gel. Solution and lotion. Mix of the water, alcohol, other of the chemicals. It can be clear or it can be milky. Least lipophilic then of the ointments, which is best at lipophilic. Most useful on the scalp. It goes through the hair, leaves no residue. Stinging and drying may result when applied to intriginous areas. So that's it. Last vehicle, foam. One of the smallest lines at the very bottom. What did I say earlier? Foam, we're not going to be using that if they're less than 12 years old. Okay? Foam is useful for scalp dermatosis, useful in areas of acute eczematous inflammation, so poison ivy, plaque psoriasis, high potency preparations. That's the reason why we don't use it in children. Do not use it for greater than 2 weeks. So you can use it for 2 weeks, but not at all. And then suppression of the hypothalamic, pituitary, and adrenal axis. So that's that foam. Now we talked about occlusion, okay? Waterproof cover enhances absorption, but like I said with here, it also occludes you, spreading all of that ointment all over the place, you know. Occlusion can increase a steroid potency by up to 100%. Consider natural occlusion when prescribing. So we need to think about what kind of occlusion could I work in those areas. I mean, do you have saran wrap at home? Because you might have to just wrap it all up or something. Okay? So, axilla, inguinal folds with obesity, diaper area. Remember, even hydrocortisone under diaper can cause adrenal suppression of an infant. So those are those things that is blocking it or is causing that. If you have a question about the infant, once pediatrics starts, you can ask her. So there it goes. So it's wrapped up in some type of a, I mean, it looks like saran wrap, but you know, it's something there that's covering it up. That guy looks amazing. His psoriasis is probably bad, or he's going into the sauna at the gym. Who knows? Seen some people do that. Topical steroid therapy. So hydration stretches into intracellular connections, and that also increases that absorption 4 to 5 times. Again, talked about the fact that if you put that application of that steroid on after some of the bathing, will help to increase that absorption. Again, you heard me say warm. It's because we don't want them in fire to where that's just, yeah, blowing everybody up. Moist wraps over the steroid and under occlusion adds that effect, so it helps that even more. Regional differences, right? So if this is on that thin stratum corneum, which is on the top of that epidermis, and increase blood flow, increase absorption. So that's why we have to be thinking about the vehicles. We have to think about the groups. If we're doing those on of the face, of the eyelids, of those thin skin areas, what do we want to use? Also, if you're going to have less absorption, that because you can have that done on of the soles, on of the palms of the hand. Okay. So those are things there. Not only do they do good, but they can have you some adverse effects. Okay. So it can cause some of the burning, itching, hypopigmentation. What does that mean? The skin is lighter than it has been because the steroid is just knocking that down. So that's hypopigmentation. They can have some of that atrophy, right? So that's that the thinning of the skin that can happen. Easy bruising, striae were those streaks. Hypertrichosis of the face. They can have some of that steroid acne, folliculitis, rosacea, dryness of the skin, worsening infection, and rebound phenomenon. Okay, those are things out there that could happen. So that's why we have to know we're going to pick the right group. We're going to pick the right, the finger tip, how much it is that they want to use. So here's some of those pictures there. So we can see that hypopigmentation of that face and axilla. We can see some of that atrophy, right? Telangiectasis. More atrophy seen in the middle, but not only that, they're able to bleed. They're able to have those bruising that is happening there. Striae, so you can see all up and down over there. That can happen. I am not 100% saying that this striae in the photo is because of steroid, but it's just showing you what it can look like, because that looks like obesity to me. But, I mean, it could be steroids, but that's what they look like. Infection. We have that acne, folliculitis, long-term daily use. There's a wonderful smile, steroid rosacea. We're going to get into that in block. No, I think we're going to get into this one. But you can get rosacea. Local effects. So contact allergy to preservative, coloring, steroid itself fails to respond, and so it's not working. It can produce a nonspecific self-supporting eczematous condition. With that, you can get exanthium, purpura, and urticaria, right? Is petechia bigger than purpura? No. Petechiae is smaller, right? If suspected, need to skin test. So that's that patch testing that we talked about earlier, which is seen in this picture right here. They put on some betamethasone valerate, and the person was allergic to it. And so that's why they have that there. Again, some systemic. So we just talked about all of the skin lesions. Now we can have some systemic also. So you can get into adrenal access. That happens more with of the children less than 2. But again, I also have in teens going through their puberty. You can see some of the Cushing syndrome, failure to thrive, stunted growth, cataracts, glaucoma. Not only do we use of those vehicles out there that we talked about, the cream, about the ointment, we talked about the foam, we talked about those things, we can use other methods out there. So intralesional or IM. Intralesional is injecting that lesion, not of the stuff around it, but you're going to tag that smack in the middle, put some of that intralesional steroid into there, and that's out there. Again, this is something not we're going to be doing in a family practice. We're going to send that out, but those individuals will be looking into those things. IM, long-lasting, easier than topical and oral, obviously, because it's going in there. But a key component is if we're having some IM, key component is local atrophy at that site, as seen in that picture right there. So that looks like that's been going in there, so you get that atrophy, you've got that induration, you've got the hypopigmentation. Those are all those things if we do it IM. Again, with the steroid therapy, most common mistakes. Steroid is too weak in the area involved, not enough medication. So what is a tube size that will push out to? Failure to follow up, too strong of kids, so we're giving them foam, too strong of the face. Bottom line, use the right potency, right steroid, right vehicle, right location, and right duration. Okay? The group, pick the right group. FTU, fingertip units. You can say other stuff, but don't say those ones, okay? FTU. So that is 5 millimeter diameter nozzle. So 1 FTU equals 0.5 grams. This is a cray-cray one to, measure it out, where you're going to use it and do those things. I don't like to get into all that crazy stuff. So know that 1 FTU is 0.5 grams. And it breaks it down, right? The key component that's not only 1 FTU, but the areas, okay? So FTU is that fingertip, right? So it's from that of the DIP down to of the tip. You can see how it breaks it down. So one hand is 1 FTU. So if you're having this on of the trunk, how many of the palms can you put over it means how many of the FTUs, right? So 1, 2, 3, 4, da 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 da. If it's on of the one leg, there's 6. Trunk, front and back is 7. So yeah, it just breaks it down into one of those things, okay? So that's adult. Well, what if we compare it to a child? What if your vignette describes the age of the individual that you want to take care of? Well, with child FTU references, it depends on their age, where they're at, and how many FTUs they're using on that children, on that child, okay? Dosing in general, no more than 40 to 60 grams of group 1 per week, because it's strong. Apply group 1 agents once a day or twice a day. Pulse therapy helps avoid tachyphylaxis, right? So let's not make them go through the roof. And then group 2 through 6, twice a day, 2 to 6 weeks. Okay? I pointed out of the key components of those things in there. Again, family practice PAs. Okay? All right. Do we have any questions? Because I'll be back tomorrow, and if you have any questions, you can ask them then too. One of the other things that I forgot to say is if you look at your schedule, there are 6 days that I have on the DERM of 1, 2, and 3. I will do all lectures on the 5th day, 1, 2, 3, 4, 5, and the 6th day is a review where I'm going to stand here and I'm going to go through all of the things that we talked about, and then I'm going to throw some fishing out there. Okay? Cool? All right, y'all.